Welcome to the North Carolina Maternal Health Innovation Community of Practice. We're so excited to have Dr. Narges Farahi here to present on the implicit network updates and quality postpartum care practices in North Carolina.
Hi, good afternoon, everyone. I'm Narges Farahi. I just want to make sure everyone can hear me. Could someone just give me a thumbs up? Wonderful. Okay, and if it's okay with you, I'm gonna try to share my screen. And
looks great.
I will.
All
How's
right.
that?
Looks great. Thank you so much, Dr. Farahi.
Yeah, thank you so much for having me. So as Suzanne said, I'm a family medicine physician and I work at UNC as well as at Piedmont Health Services at Prospect Hill Community Health Center. I have a particular passion for care of families throughout the reproductive life spectrum and perinatal and children's health. Through the Maternal Health Innovations Grant, I've been serving as the family medicine champion for perinatal Region 4 and have been involved in the IMPLICIT network before my involvement with MHI, but the two have really kind of come together in a really synergistic way. So I'm going to be sharing about the IMPLICIT network, explaining kind of what the network is, and trying to share some innovative and practical strategies to improve birth outcomes between pregnancies and after pregnancy. Let's see if I can advance. So before we got started with the IMPLICIT network, it felt really important to acknowledge this new information that has come from the CDC regarding maternal mortality. I know all of us are here today because this is an issue that we care about really deeply. And what the new CDC data shows is that maternal mortality increased 40% in 2021 in the US as the COVID-19 pandemic kind of worsened this crisis for pregnant women. We see that there are continued disparities, and Black women in the United States are 3 times more likely to die of pregnancy-related causes than white and Hispanic women. And you can see in the dark green bar that the rates of maternal mortality have increased across the board, but the disparities have also worsened. And based on the data from state maternal mortality review committees, we know that 84% of these pregnancy-related deaths are preventable. And so this is, I know for a lot of us who are really close to this is heartbreaking. And also we've seen firsthand just the direct health impacts of COVID-19, but also the strains that the pandemic has had on families and communities, on healthcare teams and healthcare systems, and the barriers that have increased to really people getting the care and support they need. So I think this is just kind of grounding us in our purpose, and we'll have time to reflect on this more toward the end for other folks who want to kind of share and weigh in. So the IMPLICIT network is a learning community that started with family medicine physicians in Pennsylvania. And they came together seeing the needs of the women that they cared for and the families in their community to really envision a future where all mothers and birthing people were fully supported to attain optimal health and wellness for themselves and their babies. And so this started with a small group of kind of rural docs who wanted to do big things, and now it's grown to many states and is impacting the health of many families. The values of the IMPLICIT network are education, collaboration, innovation, commitment, cultural humility, and justice. And you can see that there's a concentration of folks in the network in the Northeast, because that's where it started, but the network's really kind of spread, including to our work in North Carolina, the Southeast, and then also to the Midwest. And so there are now 35 sites in 10 states that are actively involved in implementing models of interconception care and 4th trimester improvement through the IMPLICIT network. Just to get a sense of who's involved in the Implicit Network in North Carolina. This slide actually doesn't have the most up-to-date information because we now have sites that are becoming involved in Durham County, as well as in Rockingham. And so it is kind of continuing to spread across the state, both in kind of family medicine and pediatric practices. And we're hoping with the kind of improvements centered around fourth trimester care to be able to engage OB practices as well, because that's really critical. So the big picture is this was kind of founded in 2003 with the first projects really being around pregnancy. So preventing medically unindicated preterm and early term births. The 39-week project was really the first project. And then realizing that there was so much need after pregnancy and between pregnancies, new models were developed for interconception care and fourth trimester care. And those are the two models I'm going to be talking about today. So ICC is a term that you'll see on a lot of these slides, and ICC is interconception care. And so this is really the care of people of reproductive age between pregnancies, from the end of one pregnancy to the conception of the next. And this includes medical and behavioral interventions to address identified health needs in women to improve future birth outcomes. I think one thing to remember is that the interconception period really starts right after birth. So this does include that critical fourth trimester period, but also extends beyond it to the period between one pregnancy and another. And so why is interconception care so important? We know the statistics around maternal mortality. We also know that going along with that, there are unacceptably high rates of infant mortality, with over 24,000 infants dying before their first birthday, and that the preterm birth and low birth weight that contribute to infant mortality are also largely preventable. We also know that there are high rates of unintended pregnancies, and that in some cases, those unintended pregnancies are not in line with the kind of goals of the patients and families. And there are opportunities there to potentially improve both the kind of patient's goals being met, as well as future pregnancy outcomes. And then we also know that people are often not receiving that critical postpartum care, but they are seeking care for their infants, and that there are multiple touch points where mothers are taking children for visits in the first few years of life, where there may be an opportunity to actually care for the mother and check in about her health. This is the premature birth rates in the US, and you can see North Carolina here in yellow. On the March of Dimes report card gets a D score. So as you can imagine, on a A through F scale, this is not where we want to be. And another reason why this interconception care model can be so important. So the implicit ICC model really works by what we call the 5 C's. So it's about connection. So really connecting more often with people after they give birth. We know that babies often have 11 visits, just well-child visits, in the first 24 months of life. And so having that opportunity to connect with mom about her baby's health, but also about her own health can be really important. Their parents are a captive audience, and so they're already there in the office, and so there's a real opportunity there to take advantage of that time. We can also document interconception care in the child's chart. So doing things like depression screening, smoking assessment are all important to the child's health, and so it can all be done there without needing to either have both the mother and child as your patient, or do any double documentation. We have developed a system of kind of comprehensive risk factor screening that we'll talk about. And then this is a model that's really built on quality improvement initiatives and PDSA cycles to make sure that this works for each individual site and can be adapted to tailored to lots of different practice settings. So the rationale behind developing the implicit interconception care model is that we do know that mothers bring their children to well-child visits, even though they may not seek care for themselves, and that mother's health and her kind of health behaviors directly impact her health as well as that of her child and family. And so inquiring about her health is a part of, again, providing care for her child and for other family members. And from early studies that were done before the model was developed, was we know that people, parents and women accept inquiry and advice about their own health at pediatric visits and actually really welcome that. So they have a really positive response to that, even if the provider is not their own care provider. And so this model really relies on repeatedly screening mothers during well-child visits from birth to 24 months of life for kind of key health and behavioral risk factors, assessing those risks at each well-child visit, reinforcing healthy behaviors, connecting people with primary care providers and community resources to address those risks. So this piece is critical. Providing prescriptions or access to free multivitamins or access to needed contraceptive services, collecting and analyzing data, and then using those CQI strategies to develop strategies for improvement. And so this is the kind of implicit interconception care workflow. You can see that you are going to be screening and supporting birthing persons. The screening involves 4 behavioral risk factor screenings that will go into a little bit more: smoking, depression, family planning, and multivitamin use. This is happening in the context of the well-child visit, and the goal is to ensure a healthy parent and healthy family. So based on the IMPLICIT network, and this is from over 100,000 well-child visits, we know that of those well-child visits, 94% of them are attended by mothers. And so they're, again, so many people are not caring for themselves, but are really present for the health of their children. We know that when we do screen for risk factors, that 64% of mothers screen positive for at least one risk factor during the well-child visit, and that 93% of them are willing to receive that advice from their child's doctor, whether that's a pediatrician, family medicine provider, nurse practitioner, PA. There's a willingness across the board to receive that advice. So kind of going through each part of the ICC screening. So when someone comes in for a well-child visit, they receive a questionnaire that has 4 key focus areas. The first one is around tobacco, and this is something that most people are screening for at well-child visits at baseline. And we know that tobacco use is linked with preterm birth, low birth weight, higher incidence of SIDS, and also impacts kind of mother's long-term health, including cardiovascular health. We also know that if we provide smoking cessation counseling, it will reduce the incidence of relapse and help people quit again if they've kind of quit and relapsed. The rate of relapse for folks who have quit smoking during pregnancy is 80% by the time their child turns a year old. And so these interventions and these opportunities to intervene are key, because many people think about pregnancy as being a time-limited kind of restriction. And after giving birth and with the stress of having a young child, can go back to kind of prior tobacco use habits that had been in place before the pregnancy. Around depression, we use validated screening tools, and different clinics use different things. So some clinics will screen directly with the EPDS, which is what we do at our clinic. Some will use a PHQ-9, some will use a PHQ-2, and then that will kind of trigger a PHQ-9 if it's positive. But we know that the kind of mental health and mood of birthing people is really critical to the health of their children. And this is recommended as a part of routine pediatric care. And it's really kind of made systematic through the implicit kind of interconception care model. And so this is done repeatedly in the first 2 years of life. And we know that with postpartum depression being so common, these repeated screenings are an opportunity to kind of capture a potential need, and then make sure that someone is able to get in with the resources that they need, whether that's being connected with their PCP, being referred to counseling, being connected with a social worker, or with the North NC Matters line. There's lots of opportunities to be able to kind of intervene if you have someone who then has a kind of positive screening. The third screening that's a part of the ICC questionnaire is around kind of pregnancy intendedness and family planning. And so there's a question both about if you're trying to conceive, and then if you're not, if you're using family planning, and if you would be interested in a different method than what you're using. And so we know that unintended pregnancy and short interval pregnancy can increase the risk of prematurity and low birth weight. And so there are missed opportunities postpartum to be able to help make sure that people have a method that they're happy with if that's in line with their goals. So the last part of the interconception care model is screening for multivitamin use. And this is another kind of easy preventative tool to reduce the risk of birth defects, and is underutilized. And so during well-child visits, we kind of screen for multivitamin use with folic acid, and it's an opportunity to either make a recommendation, or in some clinics provide access to free vitamins or prescription for patients who are not taking the recommended multivitamin during their reproductive years. So as you can imagine, if you're doing a screening, and we do this with a kind of screening questionnaire, then it's really important to have a workflow of what do you do if you have a positive screen. And so this is an example of one workflow of what actions would be taken. The key is that this workflow is in place before you start your screening process. So just like for any clinic that does depression screening, you have a workflow for if someone has a positive screen, and especially if there's an acute crisis in terms of suicidality or homicidality. And so it's really important to have those workflows in place before you start doing the screening, so that you know when you have a positive screen, kind of what the interventions might be, and who in your clinic and on your team is going to be involved. So this is one example, but I think the key is that each site that provides implicit interconception care develops a workflow for positive screens before implementing the questionnaire, so that they're really kind of prepared depending on what needs are identified and for each individual patient. And you can see here that the range of the types of interventions that can be provided are really varied. So depending on kind of the engagement and interest of the patient, and depending on how much time there is and what other needs there are in that well-child visit, you can have a really kind of low intensity intervention, or a more intensive intervention, depending on what makes sense in that visit. You can see the whole range and the types of interventions that could be provided here. Most sites have educational materials available for whenever there is a potential kind of patient need identified, to provide at the point of care to address these different medical and behavioral risks that are identified. So I wanted to share a little bit of data from the network about how this is working and if it's making a difference. So here in North Carolina, we have kind of over the last 4 years completed over 14,000 interconception care screenings with over 7,000 women in well-child visits. So these are women who came to well-child visits with their kids in the first 2 years of life. And we found that compared with our baseline data, our screening rates for tobacco, depression, multivitamin use, and pregnancy intendedness increased, as you can say, anywhere from 50 to 70% above baseline. And there were high rates of evidence-based interventions in terms of recommending multivitamin with folic acid, providing support and connection to care for depression, developing plans around pregnancy intendedness, and providing advice and resources for tobacco cessation. And we've even had one site in North Carolina find that interconception care is an opportunity to identify other medical needs. And so at one clinic, there was a high rate of patients who were had diabetes who didn't have regular care between pregnancies. And so they used the interconception care screening questionnaire to add a question about if someone had diabetes and if they'd had a recent visit. And if someone screened positive that they had diabetes and did not have a recent visit, they were able to be connected to care. And that pilot's been really successful, kind of reconnecting folks with primary care. So there are ways of actually expanding on the baseline questionnaire, depending on the needs of the communities that people are working in. This is just kind of data from the national network showing the rates of the different screens that come up, kind of what we call positive. So like if someone says, I'm not taking a multivitamin, that comes up as a positive screen. Someone says they are currently smoking, that comes up as a positive screen. And you can see the rates here that have been kind of identified across the network from the newborn period through 24 months. And you can see that even though the rates of relapse of smoking are pretty consistent, they actually kind of go up even between the 12 and 18 month period. And so there's even more opportunities to intervene. And then this shows kind of the rates of interventions. And you can see that providers and staff who are providing kind of counseling and interventions are providing it pretty consistently across the board, but it does fall off as the children become a little bit older. So there's some opportunities for kind of additional quality improvement to try to maintain that throughout those first 2 years. This is some data that I wanted to share about, does this model work? So this slide is a kind of busy slide, but what it's looking at is when there was a positive screen at one visit, was there a change between that visit and the next? And so the way that this was done is it looked at the kind of same patient, comparing the current well-child visit to the previous one to see if there was a change in the kind of the way that the parent answered the question and how that correlated with whether or not an intervention was provided in the visit before. And you can see that at the top is, did that risk continue despite an intervention? And so let's say someone is using tobacco and they screened positive. You can see here that anywhere from 55 to 72% of the time, that person continued to use tobacco at the next well-child visit, even with an intervention. But about a third of the time, that intervention was actually successful and led to a change. And this is kind of what we've seen across the network, is that there does seem to be an impact visit to visit when an intervention is provided, like counseling or connection to resources or making an appointment, which was not seen if an intervention was not provided. So we have some data that shows that these interventions are really impactful for about a third of the people who are receiving them, just from one well-child visit to the next. And I think often stories are kind of more important than statistics. And so I just wanted to share a story from my own practice about a mother that presented with a child for a 9-month well-child visit. we, as a part of the kind of intake process for the appointment, we ask parents to complete the screening questionnaire along with their developmental questionnaire for their children. On that screening questionnaire, she's kind of screened positive for restarting smoking. She had kind of stopped her birth control pills, but did not want to become pregnant, but just wasn't happy with her method. She had increased stress at home and screened positive for depression, even though she hadn't been having symptoms of depression before, and had also stopped taking multivitamins. So that same day, we were able to kind of connect her with behavioral health for assessment and support, provide brief intervention using the 5 A's model for smoking cessation, able to discuss her reproductive goals, and she was interested in starting another method, and then provide her with multivitamins. And then 2 weeks later, I was able to see her back for follow-up for her depression and for Nexplanon placement. And then kind of 6 months later, all of the screens showed a change. And so this is something that in clinical practice is really, really rewarding to be able to kind of provide this kind of reconnection to care for women before their pregnancies and see that there are these opportunities to make a difference. I now want to just kind of shift gears from kind of talking about interconception care, which is kind of that whole 2 years or more, the whole time between one pregnancy and another, to really focusing specifically on the 4th trimester. So the interconception care is one way of trying to kind of capture people who are kind of disconnected from care and reconnecting them, identifying those health needs. But 4th trimester is a just really critical period within that interconception period that needs kind of special attention. And as I know, you've heard so much from Sarah and Suzanne and this kind of incredible group at the 4th Trimester Project. And so the IMPLICIT network tried to think about a model that would help do a better job of providing care to patients in the 4th trimester. So we're going to talk about that model and the kind of pilots of that at certain sites and kind of what we're learning in that process. So I think I know there's been a lot of talk in this community of practice about why the 4th trimester is so important. And we know that, going back to our conversation at the beginning about maternal mortality, that the 4th trimester is also when people who've given birth experience the greatest rates of pregnancy-related death, as well as severe maternal morbidity. And many people are not at all getting the care they need during this time. So there's an imperative to do better for our birthing parents and their families. So the IMPLICIT network kind of tried to pilot a model to make some improvements during this critical period. And this model really aims to start in the 3rd trimester to be kind of thinking and planning for the 4th trimester, and incorporating kind of early and regular postpartum visits to provide more coordinated care for patients in these 3 months postpartum. So the kind of aims of this 4th trimester model were kind of identify patient needs and risks. So really starting in the 3rd trimester to figure out what are kind of the medical and behavioral concerns that patients have that may impact their care in the 4th trimester, and then do those ongoing assessments after birth. We really try to focus on that early postpartum visit and making sure that folks are back in those kind of first 3 weeks back to see their care provider, and then make sure that there's a kind of care team that helps provide the wraparound services, that psychosocial and biomedical support for patients in the 4th trimester. So this is an example of a clinical workflow for this 4th trimester pilot. So this begins in the 3rd trimester, and this can really begin anytime at this particular clinic. It's done at the 36-week visit where kind of in addition to discussing kind of a birth plan, a postpartum care plan, including kind of who the members of the postpartum care team are reviewed and really discussed with patients and their support people. And that conversation is really started in the third trimester. Any risk factors and needs are kind of discussed at that time. And then in some clinics, that early postpartum visit, the one that's in those first 3 weeks postpartum, is actually scheduled during the third trimester. So with the thought that let's schedule an appointment 2 weeks after someone's due date. And if someone gives birth kind of within a week of that time, that appointment may make sense, or it might need to be rescheduled depending on kind of when someone gives birth. Some clinics are not doing it that way, and they're kind of there's a workflow for scheduling appointments at hospital discharge, but this is one model of doing it, is really trying to schedule that early postpartum visit in the third trimester. Then after delivery, there's kind of dyad care in the hospital, and at hospital discharge, just ensuring that that postpartum visit is scheduled, both for kind of a visit in those first 3 weeks. Here it's kind of written as the 2-week postpartum visit, but also one that's in the 6 to 8 weeks postpartum. For family medicine practices, this has often been scheduled as a dyad visit, so that the kind of mother and baby can have visits together, and it will kind of correlate with when the 2-week well child visit and the 2-month well child visit would need to be. And so you can see that at the 2-week visit, there's kind of a focus on any concerns or complications. And then at that later postpartum visit, a really kind of comprehensive postpartum assessment is done. This is an example from one of the sites that's doing this of the kind of 4th trimester scheduling workflow. And you can see that this is kind of started in the 3rd trimester, goes through birth, discharge, and then all the way through that 6 to 8 week postpartum comprehensive visit. The goals of doing this pilot is to create a kind of postpartum registry for each site, so that there's a way of tracking who has not come to care, if anyone has kind of been lost, and identify any barriers to that person receiving kind of postpartum care during that critical period. Making sure that we're kind of doing comprehensive assessments for patients at multiple time points. So both in the 3rd trimester, right after birth, in that early visit, and then at that comprehensive visit. And then providing referrals and connections to wraparound services by a team is a primary goal as well. So I just wanted to kind of highlight the resources that are just so fantastic to share with patients in the 3rd trimester. So you all know from Sarah and Suzanne and this team that New Mom Health and the Spanish sister site Salud Madre are just fantastic resources for patients. And this is really a great thing to provide during that 3rd trimester visit, where you're starting to talk about postpartum planning, to provide this resource for patients to review at home, come back with any questions, and make sure that they are aware that this is something that somewhere where they can go for trusted information and support. There's also the postpartum toolkit, which provides really fantastic patient education around caring for birthing parents and babies. Also around a lot of the things that we focus on in the comprehensive postpartum visit, like birth control after baby and taking care of you. Those are really kind of fantastic resources that are printable right from the website. And then this is coming soon, which I'm really excited for, is a postpartum care plan that you can print out and complete with your patient during their 3rd trimester visits, to have something really kind of written down and kind of a common understanding between the patient and provider, to help make sure that everyone's on the same page about kind of what the patient's goals are, but also about kind of their needs and resources available. So just wanted to share some early data from the sites that are doing this kind of fourth trimester pilot with this kind of clinical quality improvement intervention. So you can see that from the kind of blue was before the intervention, and then the purple is after, in kind of two 6-month phases, that the rates of the early postpartum visits, as well as rates of any postpartum visits, and the numbers of people who are receiving 2 or more postpartum visits went up across the board. So there's still opportunity to do better, but seeing this improvement, I think, is really encouraging, that some of these kind of interventions and workflows on the clinical side are starting to make a difference in terms of people being connected with care earlier and more often. And the other thing that you can see is that a lot of patients have multiple identified kind of biomedical risks that are identified at their early postpartum visits. And so this just highlights the need for doing this, and, you know, even maybe a need to do get folks in more often or more regularly based on kind of what we're seeing here in terms of high rates of preeclampsia and other hypertensive disorders of pregnancy, gestational diabetes, as well as other kind of medical needs that have been identified. Just for folks to know that both the interconception care and fourth trimester models have been integrated into EHRs, including Epic, but in multiple different EHRs. And so for anyone who's interested in doing this, there are some really great templates out there, as well as kind of tip sheets for billing around both the interconception care and the early postpartum visits. One other thing is that with North Carolina extending Medicaid to 12 months postpartum, and now with Medicaid expansion any minute, these are just fantastic opportunities to connect patients with their services, not just kind of in that office visit, but making sure that they know that they are eligible for full Medicaid benefits and really what that covers more broadly for their health. And so this is a kind of one pager that's available in English and Spanish through the North Carolina Health and Human Services website. And I know that I think Suzanne and the fourth trimester project team may be working on another kind of one pager that will be available through ePass. I'll let Suzanne kind of talk about that. That will be kind of like another resource for patients as well. I think just to summarize, about the Implicit network. So this is really a network that tries to use innovative and practical strategies to improve clinical care for birthing people. We know that the interconception care model is one way of just trying to kind of identify the health needs of mothers and reconnect them to care. And it's been implemented for over 200,000 people. So we know this is feasible and effective. And the implicit fourth trimester model is still in its early stages, but the early data is really promising that we can use these quality improvement techniques to make sure that folks are connected earlier and more frequently in that fourth trimester and identify health needs so that people can get the care that they really need and deserve. So with that, I just want to thank you so much for having me here, and just going to stop sharing so I can see faces and
thank you so much.
Provide an opportunity for folks to ask questions.
Wonderful.
So definitely, I have a burning question. I'm so excited about this. So how have patients responded to getting earlier care in the postpartum period?
Yeah, Sarah, that's a great question. And I think that, you know, I can only speak anecdotally because we haven't done like qualitative interviews with patients or even kind of like satisfaction surveys with patients about the 4th trimester pilot. I will say that we have done patient satisfaction surveys about the interconception care model in well child visits, and that's overwhelmingly positive. So I think that's been really great to see. I think just from my own kind of personal experience is that I think that patients really appreciate getting more care. I think for a lot of people who are being seen so frequently throughout their pregnancy, and then just have this incredibly intense experience in giving birth and going home with a baby, in a way, I think that our kind of old model of the 6-week postpartum visit didn't make sense to people. And I think a model where people are being seen more frequently and it feels more like a continuation of care that they've received prenatally, I think that makes sense. And I haven't heard anyone say like, oh, I don't know why I'm here, or, so I think from my kind of anecdotal experience, but I think it'll be important for us as a network to also just like survey patients and both get their feedback, both in terms from surveys, but also from some qualitative interviews would be really helpful too.
Yeah, I love that, because I think having those stories and data can help make the case for others to do it. Because I remember thinking, gosh, way back, the same thing. I'm like, you all these visits, and then I had this huge life experience, and now nobody's talking to me for 6 weeks. So I'm really excited about that. Thank you.
And I know there are others on the call, like Amy Santon, and who are kind of experienced in doing implicit interconception care. And Amy has to run. I was going to say I would love to kind of hear her experience, but I think overwhelmingly what I've heard has been really positive.
Yeah, sorry, Narges, I do have to run, but thank you so much. It's just it was a great presentation and so important, and thanks for advancing this work. And yeah, we've been doing it at MHI for so long. What I would say is that like it just really becomes second nature. It's just part of our workflow that we do, and it's just so many powerful stories about interventions that were made that would not be able to be made otherwise. So it's wonderful.
Thank you, Amy. So I wanted to, since we talk a lot about in 4th trimester project about anticipatory guidance, and you mentioned that you're doing that, like, so how is that being received, and how is that timing working? Because it's always tricky to figure out what's the best time to have that conversation. I'm curious, like, what you've started to observe in your practice.
Yeah, I think it's really been a shift for me over the last few years of trying to kind of talk about the 4th trimester and postpartum period prenatally. I think for me, for a long time prenatally, I would talk about kind of breastfeeding and talk about kind of reproductive goals and family planning, but didn't really talk more kind of comprehensively about what to expect. And so that's something that I think has been just an area of growth for me personally, of really trying to be more intentional about working that in and also having a system for doing it. So I've started to add it to my checklist. That sounds like really silly. But I think, I have a checklist for tracking, like, did I screen someone for depression every trimester? And do you do all the things? And so I've added kind of like postpartum care planning to my checklist as a way of just like keeping track of like, okay, have I had these conversations? What, and then sometimes in that I'll say like, provided resources, readdress the next visit, just like little things for myself so I can kind of remember to do that. But I think before really incorporating it into my standard workflows, I would say I was doing it pretty inconsistently. I think that people have a lot of questions about what to expect, both for their baby, but also for themselves. And people are looking for that information on their own often anyway, asking trusted people in their lives, looking online, going to social media. And so I think that it's also a great opportunity to kind of learn like, well, what are people hearing? What's important to them? Where are they coming from? And then how can you help kind of bring in like evidence-based information, or just like, provide people with certain education tools, or, help make sure that they're aware of resources. So I think in just my own clinical experience, I think that it's just been a really opportunity, both for just kind of conversation and learning more about kind of where the patient's coming from, but also providing that kind of connection to information and resources that people are already looking for. So being able to kind of add to that, I think, is really helpful.
Yes, I love the focus on also that individual care, because I know that's something that we'd heard is not everyone's going to have the same worries, and not everyone's going to have hemorrhoids, and not everyone's going to have this. So I'd heard providers say, well, why would we tell them about something that they wouldn't have, right? Mm-hmm. So I really like, I think this is a good way to go, but I love how you're also listening to what are their individual concerns. I think that's awesome. Let's see, we have a question from Karen. Does the Implicit Network team coach practices to initiate the programs? So can you talk a little bit about, now that you've convinced everyone they want to be implicit, how does that work?
Yeah, so the Implicit Network is does have kind of network coordinators that help kind of provide resources for practices to start. So for example, like providing kind of existing questionnaires, examples of workflows that are in place, access to like EHR kind of documentation, tip sheets, or smart phrases, things like that. And so the Implicit Network really has like almost like a repository of resources so that you're not needing to kind of create anything from scratch, and you can just kind of either take what someone else has done or just adapt that. Same thing with like the kind of educational resources that have been developed. I think the piece that often has been trickier is that kind of really practical, how do you make this work clinically? And so this year, actually, through MHEC, through the Family Medicine Champions program, had asked me to serve in this role as kind of like a clinical liaison for implicit sites in North Carolina, or folks who are interested, just to provide that kind of like more practical clinically, like, oh, this is what we did. Or, if this is a barrier in your practice, you can try doing this part, but not this part, and really kind of approaching it from more of a just like continuous quality improvement and kind of practical perspective. So I think that that's something that has been missing. I think there are like all of these resources available through the Implicit Network, but some of that just like kind of nitty gritty, like how do you make this work in your practice, is a little bit trickier to find. I think I was really fortunate when we were starting Implicit at UNC Family Medicine and Piedmont Health, because MHEC had been doing it for a long time. And so I was able to reach out to folks there and kind of learn from what they did. But now I'm hoping to just like help support other people, just answer some of those really kind of like tactical questions. And so if, I know that Suzanne, if you want to also just like share my contact information, because it is something that this year is kind of like something that MHEC is also kind of supporting, and I'm just helping be that kind of like clinical link for folks who just want to be able to talk on that level about things as well.
Awesome.
And I see that Dr. Aristi has her hand raised.
Hi. So I just wanted to say, from a pediatrician point of view, I definitely think that this is super important work, and that we in our well child visits, we should be asking these questions on a regular basis. And I do, but I haven't figured out how to implement it so that it's documented. I feel like moms, when they come in here, they have all the paperwork that they need to fill out for their babies, the ASQs, the MCHATs. The only one that's formally given is the Edinburgh for postpartum depression. But the other questions, the smoking and the planning and the vitamins, those are just in conversation. So, and I can document on my chart, but I don't have any formal handouts. So I didn't know if you had any ideas on how I can implement that formally so that it doesn't add more to the overwhelm of the paperwork.
Yeah, Absolutely. Well, and I think you're exactly right that well-child visits have so many screening questionnaires, like you said. I think, so we use the Edinburgh too. So we do the EPDS, and so that's like its own, 9 questions. And then we use like the PEDS screening questionnaire, so it's a little bit less time consuming than the ASQ. But same thing with MChat when the kid gets a little bit older. And so we honestly, we use paper forms. I know some people do this on like tablets and other things. We're kind of like not super technologically advanced. So we use paper forms and have just like a printed out together, like on the same clipboard that has all those other things. The EPDS is one of the 4 questions. So that one's you already have. And so it's like a sheet that says like, we really care about your health. Your health is really important to the health of your family. And then it asks about kind of smoking, and and tobacco use. And I want to say it's kind of like screens for, if you're currently using tobacco, but also if you're a former smoker, just so you have an opportunity to kind of reinforce like positive changes. And then for asks about the multivitamin use. And then the family planning question is a little bit longer because it's like almost 3-part question. Like, are you trying to conceive? But it's like 3. So overall, because you're already doing the EPDS, it probably adds like 5 more questions to what you're already doing. So it's not that bad. Like it sounds bad, but it actually, because honestly, the depression screener, which you're already doing, is the longest part. So I think you're doing the hardest part already. And as you know, as a pediatrician, you can bill for that depression screening through Medicaid. So you can record that in the baby's chart and bill for it. Similarly, tobacco screening is kind of like, an AP recommendation for part of well-child visits. So you can document that in the baby's chart. In terms of documenting the other things, so I don't know if you use Epic or we use Centricity, but we have lots of Epic users. But there's, I think all scripts, there are kind of like different like smart phrases or forms that have been developed in different EHRs to try to make it so we've just kind of incorporated it in our clinic into almost like our well-child check template for 1 month, 2 months, 4 months. There's like a section where just like you have about your developmental questionnaires about like interconception care screening, and it has those 4 fields. And so it is more questions, but I honestly think because you're already doing the depression screening, which is like the most intensive part, and honestly, in some ways that the most important to know how to respond to, which seems like you already have in place, then I think you're kind of like over halfway there. And it's just kind of figuring out how how it will fit into your kind of existing documentation. And I'm happy to just kind of share examples with you too and resources, but yeah, I feel like you're already doing the hardest part. So
Thank you.
That's awesome. Thank you. And I would say that in some cases, some tobacco may be connected a little bit with mental health. That seems like that could be a good pairing. And I'm really inspired. We really need to, as a team, do some more to reach out to pediatricians with resources to make that easy for you. Well, we really appreciate this chance to have this conversation. I feel really inspired. The data is really encouraging. And it just feels like I've always been a fan of this model. Feels like you're really onto something, and I'm so lucky that we get to work with you in North Carolina. So thank you so much. And I think Suzanne's going to close out with just a couple of announcements.
Just a couple of things.
Thank you all.
If y'all can hear me, I'm sorry. I'm not usually working on just one screen. Yeah, if you wouldn't mind submitting your evaluation for today's community of practice, that's really helpful. We don't share it. Some quick updates that our next community of practice is April 27th. It's going to be lessons learned on psychological trauma and mental wellness impact on birthing families with Dr. Callie Drexler. Registration is open, and we do have the option to submit any questions you have for any of these topics in advance, just so that we can make sure that the speakers are, making sure that the presentation is valuable for your teams. And then before the next time we speak, it'll be Black Maternal Health Week. So I just wanted to share a couple of North Carolina events that are happening. Next Thursday, there's a doula town hall There's also a Black Maternal and Infant Health Conference to kick off Black Maternal Health Week in Greensboro, and then a fundraiser in Durham. So you can see the events if you want to take a screenshot or a photo. And we, of course, will be posting this on our social media.
There's also a dance party in Durham, April 14th by
That's right.
Equity.
And we are
Equity
Birth Equity has a dance party at the Museum of Life and Science on April 14th. And I will be sending around all of this information. And then a reminder that you can order toolkit materials from the warehouse. And please contact me if there's one that you don't see and that you're really interested in having at your clinic. I wanted to tease that we have coming soon a maternal health warning signs video reel with Nurse Nikki, where it's really the audio version of our one-pager of when to call 911 and when to go see a provider after you've had your baby. So that's really great because it'll be in English and Spanish, and it's kind of the audio version, audio-visual version of that. And then just a reminder that you can rewatch these previous sessions. Again, I will be circulating this recording and also some of the updates about Black Maternal Health Week and our upcoming events. Thanks so much, everyone. I appreciate your time. Thank you so much, Dr. Narges Farahi. I so appreciate you. This was wonderful.
We
I
do
appreciate your time and
appreciate it.
expertise. And we will be
Thank
sharing your
you.
contact information if that's all right.
Yeah, absolutely. Thank
All
you
right.
all,
Thank
everyone.
you.
Take care,
Take care,
everyone.
everybody.